and work really hard to get those people housed and keep them housed. And this is a cohort of 112 of the first people that we housed through this program who had enough experience pre and post for us to take a look last summer. And Dana Soderlund, who's in the room, we have to thank for this analysis, so the hard questions can go to her later. But again, just sort of at a blush, the before and after results are pretty stark. We see savings in just ED and inpatient hospital costs that more than pay for the cost of the housing unit itself, and suggest to us that if targeted appropriately, thinking about housing as a healthcare intervention makes a lot of sense. Building on those learnings where we're really leveraging housing resources that already exist, we've entered into a partnership with the Minneapolis Public Housing Authority. We're actually taking that a step further and ourselves paying for the cost of the housing intervention. And so we've entered into an agreement where we have reserved a block of up to 8 public housing units at the Elliott Twins unit over across the river. And when we identify people in our system who are either in a hospital bed or are at very high risk of readmission but cannot be safely discharged, we have, provided that one's vacant, we have a place for them to stay and be surrounded by the home care and the supports that they need. And to have a stable interim housing location while we search for a more permanent arrangement. And that's a heck of a lot cheaper than the meter running on a hospital bed. And it's something that, again, we're able to think differently and think more nimbly about how to meet the needs of a population. Job supports is another example that I mentioned briefly. Using Hennepin Health dollars, we have partnered with RISE Inc., which is a great community-based organization that does vocational services. And we've asked them to do their work a little bit differently in that we've actually given them an office right at Hennepin County Medical Center and given them access to our Epic electronic health record and said, you're now part of this whole team, this network, this fabric of people. And we again target folks who have a certain level of utilization but who have also expressed an interest in re-entering the workforce. And our clinic people and our social work people who identify people that meet those criteria have a resource. And there's now an employment specialist that's embedded and is part of the team and is able to help people with resumes, get them hooked into jobs, keep the rest of their affairs in order so that they can be successful in those jobs. And again, in addition to the benefits to the individuals served by this program, we've seen in some earlier results an encouraging financial return on investment through reduced healthcare expenditures too. And so it's really exciting when we can see that alignment and we can see these hypotheses kind of play out, where not only is it good for people's individual pride and self-sufficiency, but it has positive financial consequences on their healthcare use as well. So backing away from these individual examples, this is the aggregate experience of our utilization of primary care, emergency department visits, and hospital admissions per 1,000. These are self-reported results from our claims stream, comparing the first year versus the second year of Hennepin Health's existence. And these have been published in a couple of national journals as well, so maybe some of you have seen these numbers, but really encouraging that probably most dramatic is the 9% reduction in the use of the emergency room over the span of that 2-year period. And a comparatively more modest reduction in the overall rate of hospital admissions, although when we've dug into the data, we've seen a more dramatic reduction in the average length of stay and in the use of the intensive care unit. So definitely, as a financial metric, inpatient as a cost category has gone down more than this figure would suggest. And in a moderate way, we've seen visits to primary care increase, which is exactly what we want. We want to see people engaged with a patient-centered medical home using the outpatient part of our system. And what's not captured on this slide is a lot of great work that a lot of those professionals that I listed as workforce examples are providing that doesn't happen to get captured on a claim and submitted for payment. And when we measure utilization that way, we see an even more encouraging picture where there's a lot happening behind the scenes. There's a lot happening that our structural mainstream healthcare financing system is still ignoring, but which we believe is really the magic. And so that's been really encouraging to see as well. This takes a similar look, just restricting the view to a continuously enrolled cohort over 18 months. So this is a subpopulation of 932 people beginning in January of 2013, extending through June of this year. So we would hope and think that over 18 months, if we can keep people in the program, that should be sufficient time for some of these changes to take root. Hard to read, I'm sorry, the top line is the rate of ED visits per 1,000, and the bottom line is the rate of admissions. So when we take out the churn and the fact that those aggregate numbers represent a lot of people moving in and out of the program and circumstances changing, we see an even more dramatic picture. And not only are these changes in utilization that are more appropriate and probably linked to better health outcomes, but those, of course, the gap between what we would expect in this population and what we've observed represent very significant resources that we can reapply elsewhere in the system. And we do a lot of balancing metrics as well, so that we're sure that we're not reducing costs and improving outcomes in ways that otherwise adversely affect populations. And so what we've seen during the time period in which we've seen these utilization reductions is that we've seen some of the publicly reported quality of care measures going up, which is of course the direction we'd like to see. And we've seen patient satisfaction remain roughly on par with our system as a whole, and actually increasing, trending upwards slightly based on internally collected survey data. So this is an experiment in Hennepin Health that we're feeling positive about, but also really aware that the work is hard and that we've just begun. And so I think if anything, the pretty dramatic results that we've seen probably say as much about the dysfunction of the system as a whole and the huge and overwhelming amount of need in this population as they do about the degree to which our system has transformed. But in some ways, if we can't demonstrate that a different model will be effective on a population like this, I would argue it's going to be very hard to do it for anyone else. We have a starting point of, we expect this population to cost a lot. They have historically been uninsured or underinsured as a whole. They've been very disconnected. They've fallen into all kinds of policy gaps that we've built. And now suddenly their needs are not sprinkled among a whole lot of uncompensated care lines on balance sheets. We now have to treat them as a population. We now have to think of them as an insured group for which we're accountable for outcomes. And that has made a lot of difference in how the system views them. And so we've been able to be partnered with the university in a few ways that I want to highlight in this work. First of all, Lynn and her team have been great colleagues on a couple of manuscripts that we've submitted, and also in their role as evaluators of the state of Minnesota's state innovation model work, which is a state-federal effort to really advance the goals of accountable care. So we've been engaged with them in that work. We also have a couple of student interns that are currently working on Hennepin Health, and they're here. Hi guys. Megan and Alex, who we're happy to have brought in through the Hennepin-University partnership to help Dana Soderland and her team on a lot of the data and evaluation that we're doing internally to understand how the work is happening. And probably most significant, and our transition to Kate's part of the talk, is a formal research partnership with a number of folks from the School of Public Health, a couple of which are here today, funded by the Commonwealth Fund, where we're trying to take a much more rigorous methodological look at some of these same outcomes and to see what we can find with a more formal research approach. So with that, I'll just maybe take a quick pause and see if there are any clarifying questions or things that are burning. If not, I'll hand it over to you, Kate.
Perfect. Well, thank you so much, Ross, and thanks everybody for being here. As Ross mentioned, I am a primary care doctor trained in family medicine, and I'm currently practicing a portion of time at the Coordinated Care Center, so this ambulatory intensive care unit that Ross mentioned. And I feel very grateful to have happened upon Ross and Jennifer and the innovative work that was being done here in Hennepin County while I was a research fellow at University of Michigan. And that sort of evolved into a fellowship project, which was the sort of start of this evaluation work, and has blossomed into a full-time position as a clinician investigator at Hennepin County Medical Center and the University of Minnesota. So I am going to just give an overview, and I'm sure we could get lost in a lot of methodologic detail. I'm grateful to see John Connett here in the audience so he can help me field some of those hard questions that I'm sure are at the top of all of your minds. But I want to focus today more on a broad overview of sort of the role of research in Hennepin Health and how we're trying to set up research in synergy to the operational goals and the needs of the patients that we serve in Hennepin Health. So first and foremost, not long after I had arrived at Hennepin Health, I was appointed the co-chairwoman of the Research and Publications Committee alongside Ross to sort of try to coordinate and prioritize research and publication about Hennepin Health by internal and external partners, as well as to promote internal partnerships that result in regional and national presentations and publications. And it became clear to us quickly that there was a lot being written about Hennepin Health and a lot that people in Hennepin Health wanted to say, and those didn't always align. And when in any of these situations you have a lot of people talking about the same thing, it's a little bit difficult to kind of manage the communication and just make sure what's being said is consistent. The numbers that are being published here match those that are being published there, or at least are appropriately nuanced. So we found great success with representation from across the operational stakeholders and the different partners that Ross was describing in a desire to sort of be at the table, at least virtually, and have kind of a quarterly check-in. One of the first things we started with is where and who is talking about Hennepin Health. So we generated sort of just a bibliography of who's mentioning Hennepin Health in big ways or small ways, and just having an awareness of where that is. Across both the peer-reviewed but also the gray literature, there's been a lot of sort of reports and descriptions and case studies, and we found that it was a little bit hard to keep track of. So it was a really great start and a really nice opportunity for me to just get a sense for all that's out there. And we established then a tracking sheet so we can continue to kind of keep track of the Star Tribune articles alongside some of the others. And also we wanted a structure to coordinate participation, to sort of have some sort of internal vetting process, which I can talk more about later. But one of the early successes, I think, of this team was that there was a group from the American Academy of Medical Colleges, the AAMC, who were interested in and kind of secured early interest from Ross and Jennifer DeCubelis about talking about the workforce transformation and all that Ross implied. There's a lot going on about how the new face of healthcare providers. And this sort of went through the peer-reviewed evolution process of submitted one place and it didn't quite work out how we had expected, and so it was being retooled somewhere else. And in the process, this research and publication team came together, and so we were really able to advocate for co-authorship of some of the operational leaders who were providing all of this data alongside the very gracious first authors from the AAMC who acknowledged and recognized that they were really telling the story of people on the ground in Hennepin County. So we were able to sort of advocate for that kind of shared role and shared spotlight there. I want to spend some time today focusing on the Commonwealth Fund and the evaluation work. There's been a lot of interest there, and so we were funded for a project called Understanding the Impact of Hennepin Health, an ACO model for vulnerable populations. And this is our research team. Doug Hooley is the PI in the School of Public Health, and I'm the lead site investigator at Hennepin County Medical Center, alongside Mark Linzer, John Connett, and Jeremiah Mink from the Biostatistical Design and Research Center here as a part of the CTSA. Britton Wagner, a postdoc who works with Dr. Hooley, and Rob Krieger. Laura Guzman, who's in the audience here, my research assistant, and then Ross, as well as a patient advisory council. And we're sort of renewing or sort of expanding our collaborative approach from operational leaders working together with researchers to the actual patients who are served by Hennepin Health. And that's in early phases, but is an exciting kind of new direction of our work and our evaluation to try to kind of ensure that the work that we're doing really aligns well with the patient experience of care. So the objective in this grant is to determine the impact of the accountable care organizations on highly vulnerable Medicaid populations. So we're interested in some of the big, broad questions I'm guessing, Lynn, people are calling you about who responds best to these ACO-led interventions. Lots of questions about what are the pieces of Hennepin Health that are working? What are the pieces that are curbing utilization and generating better health outcomes? So we have this funding for 18 months to conduct some research about just the care model, and this is one diagram of the care model, but I think that it's really an opportunity to sort of look at how is this working and for whom. But Ross, as he explained, we internally, I think, have a lot of hypotheses about relationships and how relationships drive this, and we're a little bit skeptical about the the sort of piecemeal approach, the community health worker and the behavioral health expert and the housing, and that's the golden ticket. I think we are trying to both be flexible to acknowledge the flexibility of the care model and this overall approach of meeting people where they're at and responding to the priorities that they identify. And so I'm sure there are hundreds, if not thousands, of research questions we could ask of this care model. And one of the first being if this model is even an accurate representation of what happens, most specifically with the clinic at the center. I think there's a lot of work being done in some of the most exciting parts of Hennepin Health to bring that connection to primary care or that connection to healthcare out of the clinic and meeting patients where they're at. So lots to be said here. So the aim of our work, we have two aims. One, we're sort of taking a mixed methods approach. The quantitative aim is to compare healthcare utilization and cost in Hennepin Health and non-Hennepin Health Medicaid patients in 3 high-risk populations. Patients with multiple chronic conditions, patients who are high utilizers of inpatient or emergency department care, and then racial and ethnic minorities. So somewhat shaped by the priorities of our funders, as we always are in this type of work, we are really interested in drilling down on the population that Ross was describing, with a lot of focus on patients with mental illness, behavioral health conditions, involvement with the corrections facility, which we see a lot of in this group, as well as unstable housing. So they sort of